Welcome and thank you for joining us this afternoon for today's Lunch and Learn with the Doctor, Recognizing Alzheimer's Disease and Ways to Improve Cognition. My name is Kathy Chern and I am a Consumer Health Librarian at East Brunswick Public Library. Today's program is brought to you by St. Peter's University Hospital and the library's Just for the Health of It initiative to promote community health and wellness. Our speaker today is Dr. Palak Moondra, a physician in the Geriatric Medicine Department at St. Peter's. Dr. Moondra has been an attending physician at St. Peter's University Hospital since 2011, and she has additional outpatient and nursing home practice experience. Please be aware that this talk is being recorded. Participants' microphones are automatically muted and webcams are off. The recording will be available at ebpl.org/YouTube. If you have any questions, please type them into the chat box. Our speaker will answer questions at the end of the talk. Our speaker will not be able to offer personal medical advice to attendees during this program. And without further ado, I'll turn things over to Dr. Moondra.
Great. Good afternoon, all. Thanks so much for joining me for this very important topic of dementia and memory loss. I've been in practice for 11 years and do see a lot of patients for evaluation. And I think it's important, it's a very important topic, just because the prevalence of Alzheimer's disease and various other dementias is so prevalent. So it's important to identify some risk factors and other things that might help in diagnosis and treatment. I will be more than happy to answer questions at the end of the discussion. I'll go ahead and begin. So we're going to go over dementia evaluation and overview, some risk factors and causes of memory loss, and also go over some key aspects of diagnosis. So, a little bit about stats. The prevalence does double with every 5 years of increase in age. So the dementia prevalence does increase as one gets older. So for example, it might be, only 2 to 3% in your 60s, but as one gets older, even by age 80 and 80, especially 80 plus, the prevalence is in 1/3 of the population. By 2050, and I think this number has increased, more than 18 million individuals in the United States will experience some level of dementia. So usually there's a 3 to 5 year period of mild but significant cognitive impairment that precedes dementia. You may notice some, early things. And again, it's a few years before family might be, cognizant of things that are happening in terms of conversation, misplacing things, problems maybe with certain tasks at work. So again, there is that period of mild cognitive impairment prior to possibly a diagnosis of, let's say, Alzheimer's disease. The cost to society is very significant, in the billions of dollars annually, medically, long-term care placement as well in, facilities, home care costs as well, because there's a lot of caregiver burden associated with taking care of somebody with this disease. So that's something that's extremely important, and why research is so important in terms of treatments for the future. So a little bit about an overview. So there's difficulties with judgment, memory with this diagnosis. So there's memory loss plus difficulty with at least one other area, whether it's speaking, so conversation or writing, looking at familiar surroundings and maybe misjudgment there. Planning and carrying out multi-step hold on one second, I'm having trouble, multi-step tasks, for example. So, somebody who was so used to multitasking, such as, going to the grocery store with a grocery list, doing, planning a dinner for 20 people and carrying out those functions and multitasking. Those are certain things that somebody with the pathology of dementia will start having issues with. So really key for the diagnosis is that there are changes that are severe enough to interfere with one's independence and daily activities. So for example, balancing your checkbook, going to getting routine things done in one's day, finances, for example, driving, all of these things. So coming to the diagnosis, there are changes that are severe enough to interfere with these things. The disease can be progressive and unfortunately disabling. And one important thing to remember is that memory loss is not an inherent aspect of aging. Yes, we all, there are people can have senior moments. Even I forget, we forget things, where we place things, where the keys, those things can be a normal part of aging. But dementia and the pathology related is not necessarily an inherent aspect of aging. And again, wanted to point out that this dementia is different from normal cognitive relapses. So with normal aging, there's no consistent deviations, progressive deviations on testing of memory. There is some decline in processing and recall of new information. So, even with normal aging, it can get a little bit slower and harder. I think reminders work, visual tips, notes, those are things that we all are going to be doing. And again, with normal aging, there's an absence of significant effects on what they call ADLs and IADLs, which are activities of daily living, such as bathing, toileting, transferring. These are, eating, and IADLs, which are more, shopping and, taking care of the checkbook and finances, and, so that those are your ADLs and IADLs. And with normal aging, you really don't have trouble with those things. So I'm sure a lot of you have heard of something called MCI, which is mild cognitive impairment. And I see a lot of patients who I do diagnose with MCI, and they'll have problems without deficits in the main domains. And the key thing here is that there's no functional impairment in MCI. There is, though, about 10 to 12% per year progression to Alzheimer's dementia. So that's MCI. Let's talk about some risk factors for Alzheimer's dementia. So age, we spoke about, as one gets older, especially after the age of 80, we do see this diagnosis. Down syndrome, is a diagnosis that happens in a young age, and these patients do have an increased risk of Alzheimer's disease. Family history is a big one, especially with early onset Alzheimer's. So if there was a family member who had a dementia diagnosis in their, I've seen patients, and it's really tough, in their 40s and early 50s who start having these troubles. So if there's an early family history, that's something to keep in mind. And then the gene, it's an allele, the ApoE4 gene is also something that increases the risk, and is, and that's where family history comes into play and is important. So possible factors are, head injury, whether it's concussions or head trauma in an accident. These are things to also keep in mind. Fewer years of education. So, somebody who has a PhD, for example, versus somebody who may not. maybe a possible causative factor, late onset of major depression. So that's something, if a patient comes to me with, memory problems, I always do a depression screen because it can cloud a dementia diagnosis. So we do have to rule out depression. And cardiovascular risk factors are very important, such as high blood pressure, sugar problems, a history of a stroke or a heart attack, because the cerebrovascular disease, just like we have arteries in our heart and, going through the body, we have arteries and vessels in the brain, and high cholesterol, diabetes, and high blood pressure can also cause vascular changes in the brain, which, can preclude to a vascular dementia, which is actually the second most common form of dementia after Alzheimer's. So a little bit about pathology. So in Alzheimer's disease, if you took an autopsy and a brain of somebody with Alzheimer's disease, there are death of nerve cells in important parts of the brain. And key thing is a protein called beta-amyloid. So there's deposits of these proteins called beta-amyloid, and they tend to form plaques. And it becomes a disorganized mass of protein fibers called neurofibrillary tangles. So on my screen up at the right upper hand corner, you see a normal neuron. And then you see the neurofibrillary tangles in the abnormal neuron with amyloid plaque burden in somebody with Alzheimer's disease. So this is a little bit about the pathophysiology of what happens in the brain. Alzheimer's accounts for 60 to 80% of all causes of dementia. 6 to 8% of people over the age of 65 have Alzheimer's disease, which is a significant number. And nearly, looking at age again, nearly 30% of those over the age of 85 have this diagnosis. Even if it's mild, they still have this diagnosis. So let's look at memory impairment in terms of the diagnosis. Plus, one will have one or more of the following. So aphasia, problems conversing and getting the words out, apraxia, agnosia, and key thing is also executive dysfunction. So, things, multitasking, we had spoken about, managing one's finances, going through days, simple days tasks. So executive dysfunction can be impaired. There is an impairment in social or occupational functioning, and usually with Alzheimer's disease, there is a gradual onset of symptoms. So let's talk about, I think this is very important. Let's talk about warning signs of dementia or of dementia. So number one, there is a memory loss that affects daily life, and usually short-term memory is affected before long-term. So I'll have patients come in and say, Dr. Moondra, I can remember everything from 20 years ago, the year, all the facts from a long time ago, but they can't remember what they did 20 minutes ago. So short-term memory loss is a key complaint that I see that precedes, things that, like I said, from years ago. There's challenges in planning and solving problems. That's number two. Number three, difficulty completing familiar tasks at home, work, or at leisure. So that's another key finding. There tends to be confusion about maybe day, time, or place. And then trouble understanding visual images and spatial relationships is another warning sign of Alzheimer's. There may be new onset of problems with spoken or written words, and misplacing things, and losing ability to retrace one's actions is also very important. Another warning sign would be decreased or poor judgment. withdrawal from work or social activities. So for example, somebody at work will, notice that something's going on. This person will retract from social activities or interactions at the workplace, for example, and that could be a key, trigger or sign that something's going on. And again, the last one, changes in mood or personality. One can get frustrated because in the beginning of the disease, I believe one is aware that something is wrong, that they're not able to, remember things the way they used to. The short-term memory is getting to be a problem. Socially, they're not able to do the things they used to, and confusion is setting in as well. So that can trigger a change in personality and mood. One can get anxious or depressed. So these are things that are very common early on in the disease process, as well as, late disease. So one thing to remember is that in Alzheimer's disease, there is an impairment that's not due to a central nervous system pathology or problem, or a metabolic problem, such as an infection or something, electrolyte disturbance, for example, or it's not substance induced. So again, we have to make sure and rule these things out before we make a diagnosis of Alzheimer's disease or another dementia. And that the deficits are not exclusively during a course of delirium or acute confusion secondary to a metabolic or infectious process. So that's something, whether in the hospital or at a doctor's office, the physician will look into, make sure there's no urinary tract infection, make sure there wasn't an acute stroke, that there's no electrolyte abnormality with the sodium or kidney function. So these are important things to rule out, and I'll get to a few other things as well in the next few slides. So vascular dementia is something that is on the rise as more people have vascular risk factors such as hypertension, which is high blood pressure, diabetes, history of heart attack, stroke, obesity, smoking history. All of these things increase your vascular risk factors. And just, the heart and the brain are very similar. So just how one can get, arteries in the heart that get clogged with cholesterol plaques, and, then you have a heart attack. Same thing happens in the brain. There's damaged areas of brain from reduced blood flow from these clots or fatty deposits in those areas of the brain, which can cause localized areas of ischemic changes. And this is really the key in terms of a vascular dementia. It's common in people who have had strokes. So you may see an abrupt onset in a stepwise fashion after someone's had a stroke with problems. And there's a stepwise decline after one's had a CVA or a stroke. So like I mentioned before, risk factors: smoking, high blood pressure, diabetes. So extremely important to make sure, medications for blood pressure, diabetes, looking at your hemoglobin A1C, lipid profile, making sure that LDL and that HDL are at goal. So these are risk factors for a vascular dementia. And I have patients who have a diagnosis of mixed dementia because it can co-occur with Alzheimer's disease. So it's more, unfortunately, the diagnosis itself is more of a clinical one. Unless you did an autopsy of a brain after someone's passed, it's really a clinical diagnosis. There's no right now, there's no imaging test or blood work that is very sensitive or specific for the diagnosis of Alzheimer's disease, even though there's been some advancements in the last few years. Just briefly, dementia, I'm sure this is just another type of dementia with Lewy bodies where there's abnormal protein structures within brain cells. It often occurs with symptoms of Parkinson's disease, such as stiffness, slowness of movement, trembling. And in these patients, we'll see a fluctuating mental status. And a key finding is visual hallucinations. So that, they're seeing things that are not really there. This is more with dementia with the Lewy bodies. Parkinson's disease dementia is common, especially later in the course of the disease. It's a dementia that occurs, like I said, later in the, after someone's had Parkinson's for many years. I usually tend to see it latter, the latter parts of the years, but it is a pretty common type of dementia in people with Parkinson's. And there's something called FTD, or frontotemporal dementia. It used to be called Pick's disease. And this disease targets frontal and temporal lobes. And usually you'll see this diagnosis at an earlier age than Alzheimer's disease. And some of the key things are there are personality changes. Abnormal social behavior is an important one. There's speech impairment and difficulty in understanding language. Okay, so let's talk about some reversible causes of dementia. So let's say you go to your primary care doctor. Okay, mom, or I have, are having problems. What are the things that blood work or things that should be checked for? Vitamin B12 deficiency and thyroid disease are the key too. So anybody that comes in with a memory loss complaint, I'll check a vitamin B12 level and something called a TSH to make sure they don't have thyroid disease, because B12 deficiency and problems with the thyroid can cause cognitive issues. So it's important to rule those things out. Nowadays, I'm not checking as much for neurosyphilis. Before, part of the workup was, a checklist included in RPR, but not so much anymore. There is something called normal pressure hydrocephalus, which you can pick up through, it's, with a clinical diagnosis plus an imaging finding. It's a triad of a gait disturbance, some urinary incontinence, and dementia. So that can also mimic mimic the disease of Alzheimer's as well. So that's something important you want to rule out. Depression we spoke about, and drug toxicity is something also we want to make sure that's not apparent or there. So early changes, confusion, difficulty, not able to find the right words for things, difficulty expressing oneself, and difficulty with concentration and reasoning. So things, reading the paper, for example, or reading a novel, early in the course of disease, there might be trouble doing that sort of thing. Following a recipe for cooking, for example, organizing, things that you would be able to normally do, and now you're having trouble doing it. So these are some early findings and changes that can happen. Problems with complex tasks, such as paying bills or there's something going on with the checkbook, or it's a bounced check, something's going on. That's something to keep in mind. And, maybe while driving, getting lost in a familiar place. So these also can be some of the more earlier changes in the diagnosis. Later changes in the disease. There's a lot of things with behavior, such as increased anger, hostility. There unfortunately is, where there can be aggressive behavior. And I've seen that this is probably one of the top causes for nursing home placement, along with incontinence. Those two things, incontinence, where it's getting more and more difficult for the caregiver at home to manage, or behavior. Those are the top two things that I've seen, because I have quite a few patients at the Parker nursing homes. These are the top 2 reasons where I see families, even with patient care at home, for placement in a facility. Later changes also are visual and auditory delusions or hallucinations. And the medications that we have to manage hallucinations and delusions, they have a black box warning and a lot of side effects. So I'm very cautious with using antipsychotic agents and medications for these type of behavioral problems, because they do increase mortality in older folks. So we do, unfortunately, we don't have a lot of medication choices for the behavioral problems. So disorientation, needing help with the most basic of ADLs, which are eating and toileting, grooming, for example. So, they're not able to, patients are not able to do this at the later stages, and incontinence, which is, a very tough issue and problem. So screening for dementia, who do we screen for? For example, screening for high blood pressure or diabetes. You may have a question, do we screen all people for memory problems? And no, the answer is really no. The United States Preventative Task Force says there's no clear benefit to screen all asymptomatic older patients. And really, it would be older patients or their family, where families are complaining of memory loss. These are the patients that you will start the screening process, not asymptomatic individuals. So some of the things that I may use in the office before, let's say I would send somebody for neuropsychological testing. There's something called the mini cog test combined with a clock. So the specificity of this test is pretty good. The sensitivity is not as good, but where this is something, it's where I would ask a patient to recall 3 or 5 words, and in a few minutes, I would ask them to remember and recall those words. And there's a scoring system here. The clock draw test is where it's out of 4 points. I ask somebody to draw the face of a clock, put in all the numbers of a clock, and put in the time 10 past 11 with the short hand and the long hand. This is where you have the visuospatial skill that you need to be able to even do this task. And people who have early dementia have problems with this. So I love the clock draw test because it gives me a lot of information. I might ask them to, how many animals can they name in 1 minute? Arithmetic, count, so something called serial sevens, where I'll have them from 100 subtract 7 and keep going. This requires a lot of brain activity. The mini mental state exam, I'm sure a lot of you might be familiar with this, in case you yourself or a family member has taken this test. But again, and then there's something called MOCA as well, which is a Montreal Cognitive Assessment. I've done that in the office. These are just, simple tests that take 10 minutes in the office, but they do give us a lot of information, if there is something going on or something that we should be concerned about. One thing I do want to mention is that somebody who is really early may not even have a problem, and they come in and they're complaining of some short-term memory problems, or finances, or something's going on, but they score perfect on these in-office tests. I will send them, and I use JFK for a lot of my neuropsych testing, so very detailed neuropsychological testing, especially if the diagnosis is uncertain to me, or not very apparent to me. So that's something that I do utilize if I need to. So history taking, key, very extremely important, where I will ask both, when I do a memory evaluation in the office, asking both the patient and a reliable informant regarding current conditions, the medical history, current medications and medication history, looking at drug or alcohol abuse history. These are some of the key things, family history of dementia, for example. So I spend a lot of time asking questions, and a detailed history is extremely important. In terms of examination of, a neurological status exam, a mental status exam in the office, a physician such as an internist or a neurologist can do, and functional status, in terms of carrying out their activities of daily living, how functional a person is in their community still. If somebody is driving and able to, there's no issues with driving or motor vehicle accidents, and they're able to drive 4 hours, let's say, to Washington DC. Somebody able to do that, I'm really not all that concerned about, let's say, a moderate stage dementia diagnosis. Maybe very early, but unlikely. Like I said, screens for cognition. I mentioned, the mini mental, which is the Folstein's mini mental, the mini cog, neuropsychological testing I already discussed as well. So in terms of diagnosis, we have a preclinical stage, which is mild cognitive impairment, where a mini mental score will be maybe 26 to 30 points. Mild would be 21 to 25 points, and this usually, an early dementia is usually 1 to 3 years from onset of symptoms. Then we get into the middle or moderate impairment, where you have a mini mental score exam score of 11 to 20. This is after 4 or 5 up to 8 years after a problem starts. And then late or severe impairment, where the mini mental score will be 0 to 10, and this occurs after 10 years of diagnosis. Okay, let's talk about imaging, neuroimaging. Do we do neuroimaging on everybody who has memory loss or a complaint of it? So these are the patients where I definitely do decide to do either a CAT scan of the brain or an MRI of the brain. There's also something called a PETamyloid, which insurances are not really covering, and that's something that I do reserve for special situations. But somebody with early onset of a problem, for example, they're less than 65 years old, I would definitely probably do some neuroimaging to see if there's anything going on. If someone has a sudden onset or a brisk decline in their cognition, is also somebody who I would consider doing imaging in. If there's any focal central nervous signs or symptoms, maybe they've had a silent stroke, and they have weakness on one side and there's no official diagnosis, that person may benefit from an MRI of the brain, for example. Somebody who has vascular risk factors, obesity, smoking, diabetes, high blood pressure, this is somebody as well, they might have ischemic changes in the brain that can give me some insight and information on the diagnosis, and somebody at high risk for any structural pathology. CAT scan is usually the starting point. Anything major structurally going on in the brain, we can rule it out. MRI has a greater sensitivity for a stroke or an old stroke. So an MRI also, it's certain, if you ask a radiologist to really take a good look at the hippocampal area, you can get a coronal MRI to look at the hippocampus, which gets smaller in Alzheimer's disease. This is the recent advance. Again, Medicare, in some special circumstances might be covering it. Some of my patients have paid out of pocket for this test, this PET, PET CT or PET amyloid. And what it does is it can estimate the beta amyloid plaque density in the brain. So, which is a key pathophysiologic feature for Alzheimer's disease. It has a high, the nice part about it is it has a high negative predictive value. So for somebody who's coming in, you're not sure of the diagnosis, and the PET amyloid is essentially negative, you can pretty much rule out Alzheimer's disease. Usually this test is reserved for people who were really not sure about the diagnosis. If somebody is coming in with already, the mini mental is already an advanced score, you do some testing, you're pretty sure that they have the disease, this test is really not going to offer much. Like I said, it has a high negative predictive value. Okay, so I definitely wanted to go over prevention. Is there anything that you all or we all can do, to prevent? It's a devastating disease, and it's so tough to see what families go through with, loved ones with dementia over the years. And so, unfortunately, and I'm going to go through these few things. For example, exercise. Of course, there are certain protective effects of exercise. I encourage all my patients to maintain increased physical activity for as long as possible, cognitive leisure activities and social interactions. The protective effects of these remain unproven, but I really feel that my patients who are physically active and fit, who are socially interactive, they have decreased vascular changes in the brain because they're more healthy, their cholesterol's better, their diabetes is under control, they're not depressed. So all these things, like I said, even though the studies have still yet to prove that exercise and diet are, in terms of prevention, extremely important, it can hurt. Treatment of high blood pressure, which can reduce risk of stroke and cerebrovascular disease. A little bit about diet, a Mediterranean style diet. We know there's many health benefits of eating this type of diet. And again, unfortunately, the high quality evidence of the preventative effect is lacking for dietary interventions. But these are patients who I definitely see in terms of their lipid profile, their hemoglobin A1C, their weight, their body mass indexes. All of these things are much improved in patients who follow diet and exercise, things for themselves. Now let's talk about certain things. Vitamins, cholesterol medications such as statins, cholinesterase inhibitors such as Aricept, which we do use for a treatment. None of these have shown an overall benefit, even estrogen replacement or non-steroidal anti-inflammatory drugs such as NSAIDs. None have shown an overall benefit in terms of dementia prevention. So again, one may need estrogen replacement, one may need a statin. We don't use cholinesterase inhibitors such as Aricept. We don't use it for prevention. We do use it after a diagnosis of dementia to possibly slow down the progression of the dementia. Unfortunately, nothing we have can reverse the changes that are happening, but we have, a few drugs and can possibly stabilize what's going on. Ginkgo biloba, it's a naturopathic thing. Ayurvedic, all these medicinal herbs, unfortunately, also have not been associated with a reduced incidence of dementia. They looked at a large cohort of patients after 5 years of treatment with ginkgo, and they did not notice a significant improvement in cognition or reversal of dementia. Vitamin E has been, we talk about antioxidants, vitamin C, vitamin E, and vitamin E, so many studies on vitamin E. And it has shown a modest benefit in slowing disease progression in patients with already established Alzheimer's disease. But again, not for preventative purposes. So I don't tell my patients who say, who ask me, Dr. Moondra, can I take vitamin E to prevent dementia from happening? No, we don't, the studies are not indicative that vitamin E is helpful for prevention, but there is a modest benefit in slowing down disease progression. So, and the dose that they've looked at is 2,000 units a day. And again, please, this is not to tell, obviously one should ask their doctor, before starting any vitamins or anything over the counter, because vitamin E can also cause possibly, issues or maybe some inflammation for some people. So again, this is something that one would need to ask their physician regarding. A little bit, I'm just looking at the time here. It's 12:41. I think I'm getting to my last two slides, and I would love to answer any of your questions. What I can say, and again, this is after 11, 12 years in practice and doing nursing homework and seeing a lot of memory evaluations in my office, I truly am very excited about the future of Alzheimer's disease. The Alzheimer's Association, I'm going to meetings every year. There's so much research, good research in monoclonal antibodies and so many other things that are genetically modifying. And I'm excited for what the future is of this disease, of this devastating disease. It's the 6th leading cause of death in the United States. There are currently no disease-modifying therapies. We have a few drugs, they're not great. Some of the drugs have side effects, so currently, I really hope we're going to be seeing a change soon, again, with all the research that is going on. The cost, right now we're in the billions. The cost by 2050 is going to be in the trillions of this disease. The cost, the caregiver cost, the caregiver burden, the nursing home placement cost, all of these things, it's going to be in the trillions by, 20, 30 years from now. And the National Alzheimer's Plan, which they announced in 2012, was the goal would be to effectively prevent Alzheimer's disease by 2025. We're not, like I said, there's a lot of things on the horizon, and I am excited about the research that is going on. So some resources, if you guys would want to take a screenshot of this page, the Alzheimer's Association is such a wealth of information and help to my patients and their families. Here's a website. They have a 1-800 number, I believe, that families or patients can call any time of the day. AARP.org, www.aa. It's also a lot of information on there. NIH, the National Institute on Aging, in terms of studies that are going on, some research opportunities, things like that you can also find on their website. So just a few resources for anybody interested. And I think that's my last slide, and I'll open it up for questions. And thanks so much for, for taking your Friday afternoon and listening to this important topic. Thank you so much.
Thank you, Dr. Moondra. Yeah,
Sure.
so if anyone has any questions, you could type them into the chat box. And as a reminder, the doctor is unable to offer medical advice to attendees. So we have a question that was emailed earlier. Can significant stress cause the brain to mimic the memory loss symptoms of Alzheimer's?
Yes, so interestingly enough, I would say yes. I've had patients who let death of a spouse or death of a child or some very stressful situation in their lives, who come in and they have an amnestic period, which I've seen, and where they're not able to remember things, they're not able to conversate the way they used to. So yes, a stressful episode in one's life, I have, seen this occur. And, through psychotherapy and some therapy, like I said, and time, I have seen patients improve after something like this. But again, they don't obviously have the pathological changes in the brain of somebody with Alzheimer's disease.
Thank you. Okay, and now we have a question in the chat. How about the new discovery of natural products for Alzheimer's disease? Do you know of crocin, the water-soluble carotenoid found in saffron? Recent human studies showed that it is a multi-target active, having significant benefits for prevention and alleviation of AD.
Wow, that's something I will definitely look into. And saffron, we use it. My parents are from India, and it's something we use a lot in our cooking with sweets and all of that. But thank you for that comment and question. It's something I will be looking into.
Okay. Right. So if anyone has any more questions, you can feel free to type into the chat box.
I actually received a question in the DMs.
Okay.
Hold on one second. I didn't have my thing set. Hold on. I just want to be able to read it. How did you determine the date 2025 as mentioned? Also, was there any studies compared to other countries' populations? And do you have any information on food like meats intake that affect this disease?
Okay, so I believe 2020. Let me just pull up that slide here. So this day was, I think, mentioned in their whatever announcement that they gave. It was a paper that I looked at called the National Alzheimer's Plan, where that would be a goal of in terms of looking at the research that's going on. So can we definitely predict this by 2025? It's difficult for me to say. So that's where I got the date. I'm sorry, what was the second part of that question? Something regarding meats.
Well, there was actually three. The second was, are there any studies that compare like the US to other countries' populations?
Oh, so I mean, again, I didn't prepare the actual studies for this talk, but yes, certainly, studies comparing the U.S. incidence with, for example, some Asian countries, such as Japan and, India, for example, and looking at just different risk factors and lifestyle, actually, exercise and diet, and looking at various sorts of things. So yes, the studies are out there. I don't have specifics here. That wasn't a part of the talk, but yes, there have been.
And the third part was, do you have any information on foods such as meat intake that impact and affect the disease?
So, again, like I mentioned before, there's no diet, obviously eating a high inflammatory diet, red meat, such as beef and pork and all these things, versus more of a Mediterranean type style diet. We know the health benefits of the Mediterranean type diet. But no, there's nothing that says, okay, we eating more red meat, for example, versus white meat or fish, for example, more in the diet, that can cause a progression or an earlier progression, for the disease pathology, for example, and unfortunately, even though I do recommend, a healthy diet, Mediterranean diet, for example, that are, olive oil and fish-based and nuts and whole grains, unfortunately, there's a lack of evidence for right now, for example, in terms of dementia prevention. Exactly.
And then how many years from I guess it's like, how many years does it take from first diagnosis to full loss of all cognitive function?
So, this disease process in most people is a gradual process. So, I had mentioned where, I was looking at the mini mental scores, and in terms of their functional losses. So usually, and it's hard to say because everybody's different. Some people may stay at the same stage for years, and then others do have a rapid decline in 5 years. But, from beginning to end, it could be anywhere, 10, 12 years, more than that. It's like I said, everyone's progression is different, and the timeline is different. So it's difficult to put a direct correlation and age and years for that question.
Okay. And is turmeric good for preventing the disease?
Okay, great question. It hasn't, it's been studied, but again, it's turmeric, we know, is a great anti-inflammatory, and there's so many, things, and with cancer and other, arthritis, different arthritises, in terms of prevention and, helping. But no, we don't have any real data that turmeric is used for, let's say, prevention or disease alteration. But it's great. It's a great herb, to use in your cooking and food, just because it has the health benefits are there of turmeric.
And then is white matter in a brain MRI related to Alzheimer's disease?
Right. So a great question. So when we do MRI of the brain and we see white matter disease, what we're looking at is, decreased areas of blood flow and damage to those areas of the brain. So they're called small vessel ischemic changes. So vascular dementia, somebody who has a diagnosis, you may see a lot of white matter disease changes in the brain. So again, as one gets older, you can see these white matter changes, but somebody who has a lot of vascular risk factors, for example, uncontrolled high blood pressure, advanced diabetes that's not controlled, you may see a lot of this ischemic changes in the brain, which can increase their risk for dementia.
And then how do I get a relative to the doctor if he doesn't want to? Can a patient's family member have their own conversation with a doctor for a fee? And what is the benefit of a diagnosis?
So, yeah, this I think is, a lot of patients recognize, something's wrong, and it's very scary and frustrating. And yes, they may not want to go to the doctors. I think with virtual medicine, nowadays it might be, you don't have to drag your family member to the office. So yes, you can do a virtual visit, probably even as a new patient with a neurologist or a geriatrician. Obviously, then the exam is the neurological exam, which I like to do on my patients. That's not possible. But yes, I can certainly do a mini mental over the screen. So again, that's something that, yes, if you call a particular doctor's office or for neuropsych testing, I'm sure that could be done without going to the office. What was the second half of that question?
And then the second half of the question was, what is the benefit of having a diagnosis?
Well, the benefit is, I think having the diagnosis and, doing things, for example, even though, I mentioned that in terms of prevention, these things don't help, but, physical activity, cognitive activities, I still tell all my patients, please keep reading, keep doing things, going to church, meeting friends, engaging in those things. And possibly even, like I said, even though we don't have any disease modifying therapies, in early Alzheimer's disease, a cholinesterase inhibitor could be initiated and can be helpful with stabilizing the disease process. So that would be probably a benefit of having a diagnosis.
Okay, and then can transischemic attacks and or concussions push the likelihood of Alzheimer's disease?
Yeah, so we spoke about head trauma, concussions. Again, there may not be exactly a direct correlation, but TIAs, which are transient ischemic attacks, which can be precursor for strokes. Yes, these these pathological changes that happen with a stroke, with decreased blood flow, less oxygenation to, blood to brain cells, neurons, that can exacerbate or contribute to the pathology that's already going on. Such as the amyloid plaque burden and neurofibrillary tangles. So yes, a great question. This is why it's so important to control those vascular risk factors.
Okay. And then can you give us practical examples of what kind of memory loss is normal for someone, say in their 60s, and what kind of memory loss would indicate that we should go seek help?
Mm-hmm. So I think I mentioned a little bit, in terms of, there's a whole, that when we talk about neuropsych testing, there's a whole, list of things that normal memory loss associated with aging, where a little bit of short-term memory issues, okay, misplacement of certain things, forgetting somebody's name, one can delineate by some of these memory tests, whether it's normal aging and memory problems, or is it more, right? So, that testing in the office can help. The blood work, that I spoke about for thyroid and B12 could also help. And brain imaging, like I mentioned, in certain situations or cases could help kind of differentiate somebody in their 60s who is worried. And if I really can find an answer with my routine testing in the office, these are the patients I do send for neuropsychological testing, which is more in-depth testing at a center, for example. And I usually send these patients to a center at JFK for neuropsych testing.
Okay. And then a comment and I guess a question as well. A wonderful presentation. Have 2 persons in the family suffering from the disease.
Mm-hmm.
My husband seems to suffer from vascular dementia due to stroke. Please recommend the type of physician to visit for a consultation.
Yeah, so if, for example, there's been a stroke, I believe, a neurologist, not only, obviously a good, your husband would hopefully have a good internist or geriatrician just for the routine things. But a neurologist who, they see a lot of the post-stroke complications. I think a good neurologist who can monitor the neuro exam, brain imaging if needed, would be probably for a vascular dementia scenario situation, a specialist to see.
And then please explain again quickly, how and what can someone do to prevent the onset of this disease? Thank you.
Yeah, so, we went through some things regarding prevention, and unfortunately, there's lack of evidence with regards to diet and exercise and vitamins and, all of those things. So, my advice, would be to have a healthy, active lifestyle as much as possible. They're real, vitamin E, like I mentioned, it's not for prevention, it's more to stabilize progression. So I wish I had better, answers for prevention. So, but like I said, controlling that blood pressure, keeping the diabetes under control, keeping your weight down, not smoking, all of these things, increasing your physical exercise are very important, I believe.
Then is white matter beta amyloid?
So beta amyloid is a type of protein. It's an abnormal, so it's the abnormal of the accumulation of this protein that causes a pathological damage in the brain. White matter changes, you have gray matter and white matter in the brain. So it's a little bit different. And when someone has cerebrovascular disease or stroke, that affects the white matter. And that's why you see significant white matter ischemic changes on imaging. So 2 different things.
Okay, so we'll just do, well, actually, I think we're out of time for questions. So I want to just say thank you very much, Dr. Moondra, for taking the time to present on this topic and to answer all of our questions.
Yeah, it was a pleasure, and I hope everyone enjoyed the talk.
All right, thank you. Yeah, and then also for everyone who joined us, thank you for joining us for today's talk. And also please join us for our next Lunch and Learn with St. Peter's University Hospital. And that topic is on asthma. So finding the E's in your wheeze on Friday, June 25th at 12 p.m. For more information or to register, go to ebpl.org/calendar. And again, thank you for joining us and take care and stay safe.
Take care.
Thank you.
Have a great weekend, everybody.
Thank you. Have a great weekend.